Assalamualaikum and good morning. Today we are going to learn about lesions affecting the tongue. So we are just going to recall back about our tongue. So it's a mobile organ. You have to remember, because sometimes when you see patients and suddenly the patient cannot move the tongue, then it means something wrong, because tongue should be a mobile organ. It has specialized epithelial lining. So it's not only it can feel the pain, it can feel hot and cold, but more than that, you can taste with your tongue, which you cannot have it in other places. So it rich in blood supply and sensory nerve endings. It's special due to the papilla, and it's always the forgotten organ to be examined. You have to always remember too, because since tongue is rich in sensory and blood supply, if you want to do any biopsy, you have to be very careful because of the bleeding. And most of the neural tumor will have on the tongue. Okay, so basically this is the anatomy of the tongue. You can have a look just to recall back. Okay, this is the tongue. Can you see dots over there? Those are the papillae. Sometimes the papillae may be a little bit larger. Okay, and some of the dentists will refer to us. I don't mind getting the referral as long as you know that you are covering the patients, making sure that the patient getting the best. So we are just going to play a short game. It's just very bored, just me alone, but we play the game. You can answer it with your friends or your own self. So do you think this is something nasty going on? It looks beautiful. And what's this? We are going to learn later. And how about this? It looks red, it looks like a tongue, but it looks different, slightly different. Okay, so what are the objectives that we are going to learn? You have to know how to classify and recognize the signs and the symptoms when the patient have any lesions on the tongue. The investigation that lead to the diagnosis. You have to know the etiologies and treatment. And briefly, you have to know the histological features. Okay, the diagnosis, if it's something which is complicated, just get the differential diagnosis. But if it's something which is straightforward, then you have to know the final diagnosis. Okay, so for the lesions of the tongue, there are broad differential diagnosis. Most of the lesions, if it's something which is benign, it will resolve spontaneously. But if it's something which is nasty, of course, it's going to take more than weeks. Okay, if you have something which you are uncertain, so you have to biopsy or you have to evaluate. Don't be scared to refer the patient, or don't be scared to review the patient frequently, rather than you miss something which is very, very wrong. Okay, some of the tongue lesions might be actually manifestation of systemic diseases. Okay, so that's a long tongue there. So the classification, we can classify it into developmental or acquired. This is the very common one. Acquired, it might be because of infection. Inflammatory, it means because of systemic or some problem with your immune system. Neoplastic, traumatic, or something you are not very sure, idiopathic. So with developmental, you may have microglossia, macroglossia, ankyloglossia, lingual, thyroid, and fissured tongue. We are going to have a look. For acquired, for inflammatory, for example, if it's due to systemic problem, you might have some tongue problem due to amyloidosis, okay, anemia, and foliate papillitis, or because of medication, which is very common. If it's because of infection, these are the common infection that can cause lesion of the tongue. Okay, if it's neoplastic, okay, then it might be any kind of tumor, benign or malignant. The most common one is squamous cell carcinoma. Idiopathic, you have black hairy tongue, geographic tongue, hairy leukoplakia, varicosity. And if it's trauma, you can have ulcer or even laceration of the tongue. Okay, so are you ready to go? Okay, so what is microglossia? You know from the word micro, it's small, and glossia means tongue. So it's something which is small tongue. It's very rare with unknown etiology. Usually it's associated with other anomalies, for example, cleft palate, mandible hypoplasia, or missing lower incisor because of the constriction of the mandible arch. So the treatment is usually none, or if it's the patient having difficulty with eating, with speaking, then you might have surgery. So this is oromandibular limb hypogenesis syndrome. This is microglossia. So microglossia usually with type 2. Okay, even hypoglossia means there's no tongue at all. Okay, so this is small tongue. Can you see missing incisor, and the mandible is very small. Okay, so the opposite of microglossia is macroglossia, big tongue. So usually you can define big tongue if the tongue protrudes beyond the teeth during the resting posture, or there's impression on the teeth on the lateral border of the tongue. It can be congenital or even acquired. Okay. So if it's congenital, it can be because of lymphangioma, hemangioma, facial hemihypertrophy, cretinism. Okay, you remember cretinism because of your thyroid, Down syndrome, neurofibromatosis, a benign tumor, multiple endocrine neoplasia type 3, or other various syndromes. If it's acquired, for example, okay, just now it's congenital if you have hypothyroidism and you have cretinism. But acquired means sometimes if you remove your thyroid and you have hypothyroidism, then there will be accumulation of matrix glycosaminoglycans in your tongue, and you have macroglossia. Acromegaly, infiltrative disease such as amyloidosis, sarcoidosis, okay, neoplasm of the tongue, trauma, infection, and some vitamin deficiencies. Okay, so what are the clinical features of macroglossia? Okay, how do you know you are having macroglossia? For example, if you have noisy breathing, there's drooling of the saliva, you have difficulty in eating because you keep on biting your tongue, you have open bite because the tongue keep on protruding, okay, because the tongue is too big, it always push the mandibular, so you have mandibular prognatism and even sometimes choking. Okay, we go back here. So for example, amyloidosis is the deposition of the amyloid. Amyloid is a protein. Okay, I do not know if you already learned in general pathology, but for our students, we taught them in general pathology. Sarcoidosis is unknown, and then they have these giant cells. Okay, so with infection, you've already learned Ludwig angina, which is very important because it can obstruct the airway. Okay, so that's why with macroglossia, it is actually more emergency. If it's acute, it's more debilitating compared to microglossia. Okay, so the clinical features of macroglossia will be depending on the systemic problem. Okay, for example, if it's hypothyroidism, usually the tongue will big, but it's smooth. Okay, and the tongue is generalized big. It's not like localized big in certain areas. If it's other etiologies, especially cancer or any tumor, then usually it will be nodular. Okay, depending on the site where the cancer resides. And then if it's lymphangioma, usually it will be pebbly. It's more like vesicle, big vesicle, or big blisters. So we usually call it sometimes frog egg or tapioca pudding appearance. If it's Down syndrome, okay, usually tongue surface will be more papillated and will be fissured. And it's also diffuse enlargement. Okay, so can you see there's indentation on the lateral border of the tongue? So this is maybe one of the sign of the macroglossia. But you have to remember, it's actually a ratio. Sometimes maybe because the mandible is very small, but the tongue is normal. So you may get the indentation too. Okay, so that's the one, indentation on the lateral border of the tongue. Okay, so can you see? Okay, this is not the generalized macroglossia. It's more nodular. So if it's something like this, it's maybe some sorts of tumor going on. Okay. Okay, so this is because of hemangioma. Maybe can you see it's more like bluish lesion. Okay, it's nodular. Okay, so this is where you have cracks. Okay, on the tongue, fissured tongue. Okay, fissured tongue is we are going to discuss about it later. Okay, the histology and treatment. The histology and the treatment, of course, it depending on the etiology. Okay, if it's because of, for example, amyloidosis, then you are going to have the amyloid protein. So how you want to see amyloid protein? So usually it's going to look glow in the under apple preferences or certain types or Congo red stains. If it's, for example, because of sarcoidosis, then you are going to have giant cells. And some of the histology, for example, basically just because of syndrome, then there will be no histological changes. The treatment will depending on the severity. If it's really involving or it's actually affecting the quality of life, then you are going to have speech therapy or some surgery. But if none, then there will be no treatment. Okay. So we'll go to hemangioma. Hemangioma is hamartoma. Usually you have localized proliferation of vascular vessel, either cavernous or capillary. It's more common among female and children. It can happen anywhere, skin, mucosa, even bone and muscle. Usually it will be soft, okay, very well circumscribed, localized, and it will be painless. Just like I showed you before the picture, it will be red or blue color. Okay, so depending how the size of it, usually it's cavernous, that it will be bigger. It can be part of syndrome of Randall-Osler-Weber syndrome or Sturge-Weber syndrome. So you have to always remember, if it's something which is red or blue color lesion, you have to always check about blanching test. If you can still remember, I think I taught you during investigation. Okay, so blanching test is very important, because if you want to do any biopsy, then if the blanching test is positive, it means it's something which is still in the vessel. So if you do a biopsy, then you have a very profuse bleeding. Okay, so this is the example of hemangioma. You can see nodular, red, blue, bluish color on the tongue. Okay. Okay, that is a very big hemangioma tongue. Usually it's among children and ladies. Okay, this is on the lips. So that's not part of, okay, so this is part of Sturge-Weber syndrome. We are going to learn later. Okay, so hemangioma, the radiographic features, if it's in the bone, it's going to be finely trabeculated radiolucent. But if it's in the soft tissue, of course, you cannot see it's under radiograph. Usually, okay, you have to do ultrasound. Ultrasound is very good, even on the tongue. So you have to always remember, blanch it. It's going to be blanched on the glass slide. Treatment, you can leave till puberty, because usually it will convolute when puberty. You can excise it using sclerosing agent or strangulation or cryosurgery. It's not the normal excision. If not, it's going to be profusely bleeding. Okay, the histological features, of course, there will be proliferation, a lot of blood vessels. It depending the types, is it capillary or cavernous. If it's capillary, you know that capillaries, they are small channel, so it will be multiple small. If it's cavernous, so it's going to be big. Okay, so large, tortuous, dilated vascular spaces like this. So this is more like capillary. Okay, it's small. This is the capillary. That's the endothelium. Okay, the spaces there. Okay, this is also capillaries. Okay, this is cavernous. Can you see? It's a lot big, very big, and lots of red blood cells inside there. So this is syndrome associated with hemangioma, Rando-Osler-Weber syndrome. So it's autosomal dominant. There will be lots of telangiectasia on the skin and mucous membrane, even inside the organs. It will be dark red because of the vessels. The vessel may be even large, 2 to 5 millimeter, which means very large. And usually the bleeding will be continuous. The initial sign